Okay, let's dive right in. We're looking at something your sources are calling a quiet crisis. And it's a topic they argue, well, it's been largely ignored, maybe even distorted. We're talking about men's health.
Yeah, and it's not just, the physical stuff like checkups and diseases. It goes way deeper. It covers the physical, sure, but also mental health and even the societal dimensions that shape men's well-being.
It seems like a really complex picture right from the start.
Definitely. They're not just listing symptoms or problems. They're trying to pull back the curtain on things like biases in research, challenging some common myths, especially around psychiatric care.
And exploring those really deep-seated reasons, culturally, socially, why men might suffer in silence.
Exactly.
And as you get into this material, you'll see pretty quickly it touches on some sensitive areas.
Oh, for sure. It includes critiques of different gender discourses, challenges some established narratives about health and gender.
Absolutely. So let's start by unpacking that common narrative. You've probably heard versions of this yourself. The statistics showing women, on average, are prescribed psychiatric medication more often than men.
Right. And the common interpretation is that this difference is often used as simple, direct evidence. Evidence that women's lives are maybe inherently harder or that they face, clearly greater mental health challenges than men do. What if that statistic, which seems so straightforward, actually tells a much more complicated story, maybe even the opposite story?
What if the fact that women are getting those prescriptions isn't just about who has the issues, but about who's actually getting help, about access?
Exactly. What if it shows that women are, relatively speaking, getting into the healthcare system? They're seeing doctors, they're getting diagnosed, they're accessing treatment.
And the real crisis might be that men just aren't even making it through the door. They're not getting into the system to even begin that process of diagnosis and care.
There's a perceived difference in how suffering is discussed. Female suffering is often highlighted with a lot of empathy, leading to calls for systemic change, policy proposals, big campaigns to address root causes.
Okay, lots of focus on solutions and understanding the context.
Right. But in contrast, male suffering within that same framework often gets downplayed or dismissed or even framed as being self-inflicted. Maybe a result of men's own choices or flaws.
Less empathy, more judgment, perhaps. When we talk about health outcomes, access to care, especially mental health, why does it seem that the other half of the population, men, has, in some really critical ways, been left behind?
That's the question driving this whole deep dive.
Okay, so building on that, let's dive deeper into the mental health side of things. Moving beyond just those prescription numbers to get the broader context.
Right. It is empirically true. Women are prescribed psychotropic medications more often than men. That's a fact in the data.
But if higher prescription rates for women don't just mean women have more mental health problems, what does it primarily reflect?
This data point actually reflects really significant critical differences in help-seeking behaviors between men and women, and that these behaviors are deeply tangled up with societal norms and expectations.
So less about the illness itself and more about who feels able or is encouraged to step forward and say, I need help.
It's about who accesses the system, not just who suffers.
And what kind of evidence do the sources bring to back this up, this idea about different help-seeking behaviors?
Well, they point to quite a few studies. Research that consistently shows men are significantly less likely to seek out mental health treatment compared to women.
And this isn't just a small difference.
No, it's a substantial gap seen across different populations, different settings. Men just aren't showing up in the same numbers at therapists' offices or doctors' clinics to talk about mental health stuff.
Why not?
One is the deep-seated stigma around mental health issues in general, and the other is the influence of traditional masculine norms.
Okay, tell me more about those norms.
These norms often promote this ideal of, stoicism, being self-reliant, keeping a stiff upper lip, showing emotional strength.
So expressing vulnerability, admitting you're overwhelmed, or saying you need psychological help, that clashes with the ideal.
Exactly. It can be seen as a sign of weakness, and that creates a really powerful cultural barrier that stops many men from reaching out, even when they're struggling.
So if men aren't seeking professional help when they might need it, what are the consequences? What happens to those mental health issues?
They often go undiagnosed. And crucially, because they're undiagnosed, they go untreated.
But the problems don't just vanish, right?
No, this lack of professional help doesn't make the issues disappear. Instead, men might turn to alternative ways of coping, often ways that are less healthy in the long run. Substance abuse, things like alcohol, opioids, other drugs, and also aggression.
And they frame these not just as bad choices, but potentially as symptoms.
Right. The sources present them frequently as symptoms or outward signs of underlying, unaddressed mental health struggles. Struggles that haven't found a healthier outlet or haven't received the right clinical care because the person didn't seek or couldn't access help.
Hmm. The sources also add another layer to this critique, one aimed at the mental health services themselves.
Yeah, that's an interesting point they raise. They suggest that these services have faced criticism in some analysis for being inherently feminized.
Could that potentially alienate men?
It could refer to a couple of things. One is the fact that the mental health field has a predominance of female practitioners.
Which might be a barrier for some men.
For some men, yeah, due to cultural norms about discussing personal emotional stuff, maybe particularly with women they don't know. The sources also point to therapeutic approaches that heavily emphasize emotional expression, talking things through, showing vulnerability.
Which are effective for many people.
Absolutely. But these approaches might not immediately click or align with the preferred communication styles or comfort zones of men. It might feel foreign or uncomfortable, further discouraging them.
Okay, so let's put this together. If we just look at the prescription data and ignore these other factors,
Yeah.
the differences in seeking help, the stigma, maybe even the nature of the services themselves, what are the negative consequences of misinterpreting that data?
By focusing only on the higher prescription rates among women, the main story people tell inadvertently reinforces a really problematic idea. The idea that mental health challenges and the need for treatment are mostly a women's issue. This cycle directly exacerbates the very mental health disparities we started by observing in the prescription data.
It really shows how the story we tell about the data can be just as important as the data itself in shaping what happens next.
Precisely. And if we really want to address these disparities effectively, we have to acknowledge this complex mix of factors: how societal norms shape behavior, the practical realities of who seeks help and why, and how accessible and relevant the available services feel to different groups.
And the conclusion here is that making things better requires moving beyond simplistic gender stereotypes and developing strategies that work for everyone, recognizing that different groups might need different approaches or encouragements to get the care they need. It's not about downplaying anyone's struggles, but seeing the different hurdles people face.
Yeah, it's about creating more pathways to help, essentially.
Okay, let's unpack some of these specific areas.
And that's why
and
it's
go into detail on suicide rates and postvention. What's the stark context?
The context is frankly tragic and unambiguous. Men account for the vast majority of deaths by suicide worldwide. This isn't a small statistical blip or something specific to one region. It's a consistent global pattern.
It's a leading cause of death for younger men in many places.
Yes, in many Western countries, suicide is actually the leading cause of death for men under the age of 50. It's a huge public health crisis, specifically impacting men. Despite these overwhelming numbers, suicide prevention programs and the efforts around them are often not properly tailored to men's specific needs. They might not fit men's communication styles or address the unique pressures men might face. The approaches used might simply not resonate or reach men effectively. Why are male-specific suicide prevention strategies approaches actually designed with men's unique barriers and ways of communicating in mind? Why are they so consistently underfunded and underdeveloped compared to the massive scale of the crisis among men? It's a direct challenge to priorities.
Moving on, the sources discuss substance abuse, often framing it as a form of self-medication. The context here is also pretty stark.
Yeah, the data shows men disproportionately suffer from addiction to alcohol, opioids, other substances compared to women, another significant disparity. These high rates of substance abuse among men are frequently a direct result of untreated mental illness. When mental health problems go undiagnosed, unaddressed, men, maybe feeling constrained by stigma or norms against showing vulnerability, might turn to substances as a way to cope, to numb the emotional pain, the anxiety, the depression.
The sources mention a researcher, Vincent Straub, in this context. What does he highlight?
Straub's work focuses specifically on those societal norms promoting stoicism and emotional detachment in men. He draws a direct line between these cultural expectations and poor outcomes, both mental and physical. The core idea is that suppressing emotions doesn't make problems go away. It often just pushes them into more destructive channels, like addiction.
And Straub has a somewhat unusual advocacy mentioned in the sources.
Huh, yeah, maybe unexpected. He advocates for encouraging men to read fiction.
Fiction, why?
His rationale is that engaging with stories, with characters, with complex emotional narratives in fiction can be a powerful, maybe less direct or threatening way for men to develop their emotional literacy and empathy. It offers another route to processing feelings, away from direct personal disclosure, which might feel difficult.
That's interesting.
Our addiction treatment models, the way they're typically structured, implicitly design more around women's communication norms, norms that often involve more verbal processing, more open emotional expression. Again, the support system itself might be less effective for some men because of its design.
Okay, another critical area, male homelessness and healthcare neglect. The numbers here are quite shocking.
They really are. In many countries, men make up something like 70 to 80% of the homeless population, a huge majority.
A massive disparity that you really don't hear about very often.
Even though they're the vast majority of the homeless population, homeless men often get less targeted aid. And crucially, they get significantly less consistent medical follow-up compared to other homeless groups or the general population. They fall through the cracks of the healthcare system even more easily. Why is the intersection of homelessness and male health so consistently invisible in policy discussions, in funding priorities, in public awareness?
Then the sources tackle iatrogenesis in male patients. That term, iatrogenesis.
It refers to harm caused by the medical treatment or system itself, often due to errors or neglect or biases. The sources give examples like doctors potentially ignoring symptoms of osteoporosis in men because it's often thought of as a woman's disease, or maybe downplaying the pain men report based on stereotypes about male toughness.
So the angle here is that assumptions, gender norms, stereotypes held by medical professionals can lead to diagnostic shortcuts or biases that actually harm male patients.
Precisely. Assumptions about how men should present symptoms, what conditions they're likely or unlikely to get, or how much pain they should tolerate these can lead to misdiagnosis, treatments being delayed, or just inadequate care, specifically because the patient is male.
The sources cite Dr. Zach Seidler here from Movember's Real Face of Men's Health report. What does he discuss?
Seidler's work directly tackles how those ingrained stereotypes of masculinity, being stoic, not complaining, being tough, actively get in the way of open, honest conversations between male patients and their doctors. Men might downplay symptoms because they feel they should, and doctors, perhaps influenced by the same stereotypes, might be less likely to probe deeper or consider certain diagnoses in men.
And the potential outcome of this dynamic, according to Seidler.
Tragically, it frequently leads to diagnoses for serious conditions being delayed. And those delays mean treatments start later, are less effective, and can result in preventable deaths among men. It's a dangerous combination. The patient's reluctance to speak up fully, potentially amplified by systemic biases.
How often do men suffer harm, maybe even die, because of an underlying assumption that men are fine unless they are actively bleeding?
It's a stark way to put it, but captures the essence of the concern.
Another area the sources argue is neglected: reproductive and sexual health for men. The context they provide is a big disparity in research and funding.
Yeah, they state that far more resources, far more attention globally go towards female contraception, fertility issues, and general reproductive health care compared to the male side of things.
And the angle is that male contraception research, for example, is decades behind where it could be, despite interest.
Yes. The sources emphasize this gap. They point out that even though sharing the burden of contraception is something many couples and individuals are interested in, research into effective male methods gets comparatively very little investment worldwide.
They cite Sijo J. Parakattle, author of a book on male infertility. What's his emphasis, according to the sources?
Parakatel's work, as described, stresses that a significant number of the causes behind male infertility are actually treatable or even preventable with the right knowledge and care. This highlights a major area of male health where, with more attention and research, we could see really significant positive changes for individuals and couples.
And what does Parakatil call for specifically?
Increased public awareness, definitely, but also significantly more dedicated research focusing specifically on male reproductive health issues, going beyond just infertility to cover the whole spectrum.
Why is male reproductive autonomy and health treated as such a consistently low priority in global health research agendas and funding decisions?
Then we have disparities in caregiving and end-of-life care. The context here is that statistically, men are less likely to receive adequate support from caregivers as they get older or become seriously ill, and they're also less likely to access palliative care services compared to women.
Connect back to earlier themes like stoicism.
Yes. They suggest that the learned stoicism in many men might reduce the perceived need for caregiver support both by the men themselves, who might resist asking for or accepting help, and maybe even by their families or healthcare providers who might assume they're coping. But this stoicism also seems to limit their actual access to that crucial support when they genuinely need it most, especially towards the end of life.
The sources mention Michael Marmot, known for his work on social determinants of health. How is his work applied here?
He talks about how social determinants, things like the conditions you live and work in, cultural norms, social position, fundamentally shape your health choices and outcomes. Applied here, societal expectations around masculinity, independence, and stoicism act like social determinants for men. They might disadvantage men by constraining their ability or willingness to access necessary caregiving and support services, particularly in old age or terminal illness, compared to women who might not face the same cultural pressure to appear completely self-sufficient. Are elderly or terminally ill men being systematically undercared for within our current healthcare and social support systems, partly due to these ingrained norms and expectations?
Finally, in this long list of overlooked areas, the sources bring up COVID-19 disparities, a very recent, clear example.
Right. The context is that during the pandemic, men were disproportionately affected. They experienced significantly higher rates of severe illness and higher mortality rates from COVID-19 compared to women. Studies from numerous countries consistently showed this pattern. Males had notably higher rates of being hospitalized, ending up in intensive care, and dying from COVID-19 compared to females. This was seen across different age groups, though the gap often widened in older populations.
Do they cite any specific data?
Yes, they mention data from Italy early on, where men made up a significantly larger percentage of the total deaths, with the risk climbing sharply from age 50 onward. They also cite the Chinese CDC reporting a death rate of 2.8% for men versus 1.7% for women in their initial large study.
What factors contributed to this disparity? It wasn't just one thing, presumably.
No, it was likely a mix of factors. Potential biological differences, maybe variations in immune responses between sexes. Also, the higher prevalence among men of certain pre-existing conditions like hypertension, heart disease, and diabetes, which were known risk factors for severe COVID. Also, behavioral factors like historically higher smoking rates in men in many countries and potentially higher risks due to occupational exposures in male-dominated jobs.
Wow. Okay, so looking across this whole range, mental health access, suicide, substance abuse, homelessness, potential medical bias, reproductive health neglect, caregiving gaps, even COVID outcomes, the sources are really building a case. They're arguing there are significant, measurable, and often just plain ignored health disparities that specifically hit men harder. It's a much broader and bleaker picture than maybe we usually consider.
It absolutely is. And laying out this broad picture of neglect and disparity sets the stage perfectly for the next major section.
Gender bias within medicine itself.
It's important to start by acknowledging the history here. It's very clear that feminist advocacy, especially in recent decades, played a crucial, absolutely positive role. It was vital in uncovering and pushing to correct serious medical biases that were harming women.
Like women being excluded from research trials.
Exactly. That historical exclusion meant less data on how treatments actually affected women. Plus, the tendency for conditions primarily affecting women or presenting differently in women, think endometriosis, or even heart attack symptoms to be dismissed, misdiagnosed, called hysterical. The source explicitly says feminism rightly demanded a reckoning for these dangerous biases.
Okay, so that positive historical role and impact is clearly acknowledged.
While that critical spotlight on biases against women was necessary and led to vital changes, it has often come with a troubling blind spot.
And that blind spot is
The pervasive, often unexamined assumption that gender bias in medicine only disadvantages women, or at least primarily disadvantages them.
and who is making this critique? Is it coming from one particular group?
It's coming from a growing number of voices, people ranging from those associated with men's rights advocacy to more mainstream, academically oriented gender scholars. This concern about the blind spot isn't just confined to one narrow political corner.
What's the core argument these critics are making?
Their argument essentially is this: while those feminist critiques were vital and brought much needed attention and resources to women's health issues and the biases affecting them, that intense focus often inadvertently ignores, downplays, or even dismisses the significant ways men are also disadvantaged within the very same healthcare systems. It's not an either-or situation, they argue.
And the result of this focus, what kind of narrative does it create?
It results in a skewed narrative, a story that tends to position women as the main, sometimes the exclusive, victims of medical bias and systemic problems. Meanwhile, men are often portrayed either as the default beneficiaries of the system, because research used to be mostly on men, or conversely as the cause of their own health problems through bad choices or clinging to toxic norms. This intense focus on women's health, while achieving vital gains, can inadvertently obscure other forms of gender bias happening simultaneously within the system, specifically biases that negatively impact men's health. It draws attention away. This lens sometimes defaults to viewing men in one of two ways: either as the sort of unproblematic default human model that medicine was built around, which ignores male-specific issues, or as simply creating their own health problems through behavior.
So it struggles to see men as a group with their own overlooked health challenges and systemic disadvantages.
This perspective sometimes fails to recognize that men, too, face distinct systemic disadvantages in healthcare that need specific attention, not just assumptions or blame directed at individual men.
Okay, let's look at the specific critics and perspectives the sources cite to build this argument. First, Christina Hoff Sommers and her book, Who Stole Feminism?
Right. Summers' critique of what she called gender feminism. She argued it was ideological and, importantly here, selectively compassionate. These frameworks tend to strongly emphasize women's suffering and disadvantage while minimizing or even ignoring areas where men face significant disadvantages. Explicitly, health, education, and family law.
Is there a quote that captures this?
Yes. Feminism, in its current form, often starts with the assumption that men are oppressors and women are victims. This doesn't leave much room to recognize when men are the ones being neglected or harmed.
Then there's Paul Nathanson and Catherine K. Young, authors of Legalizing Misandry.
Their book is a detailed critique, arguing that various cultural and legal systems are actively marginalizing men. When applied to healthcare, Nathanson and Young argue that the disproportionate focus on women's health issues, they use breast cancer awareness campaigns, as a prime example creates a significant imbalance. An imbalance in research funding, in public awareness, in overall societal concern compared to equally serious men's health issues like prostate cancer.
And there's a powerful quote linked to their perspective, too.
Yes, a very pointed one. We have allowed ourselves to believe that compassion is a gendered virtue, that it only flows toward women. But men bleed too, suffer too, and die young far more often. Why are we so comfortable ignoring that? It's deliberately provocative, directly challenging where society directs its empathy.
The sources also mention the men's rights movement more broadly.
Yes, this movement has, for a long time, pointed to specific disparities. Things like the funding gap between breast cancer and prostate cancer research, especially when you compare funding per death or prevalence. They also highlight male suicide rates, the high number of workplace deaths among men, and underdiagnosed male mental health issues as examples of critical problems that, they argue, receive comparatively little institutional attention or public advocacy, particularly from mainstream gender equality movements.
Richard Reeves, in his recent book of Boys and Men,
Reeves, who's a scholar at the Brookings Institution, presents a very data-heavy case. His argument is that men and boys are currently falling behind in several key areas globally, including health outcomes, but also educational achievement and economic prospects. His work, as presented, specifically calls out what he sees as a tendency within many progressive institutions and mainstream gender discussions to dismiss men's struggles, either framing them as self-inflicted problems or simply seeing them as less worthy of focused intervention or empathy compared to issues faced by women and girls. Men are facing a crisis, and the lack of institutional empathy is staggering. If we replaced men with any other identity group, the silence would be considered scandalous. He uses that hypothetical switch to really hammer home the point about perceived indifference.
Charlotte Mortlock, an Australian journalist writing just recently in 2024, what makes her perspective notable here?
It's a rare feminist critique of feminist discourse itself. So a critique from within, so to speak. Mortlock argues that for gender equality efforts to be truly effective and move forward, the next wave must take men's mental health seriously.
And she warns against certain narratives.
Yes, she warns that continually framing men primarily as the source of systemic problems, rather than also acknowledging them as potential subjects of systemic disadvantage, isn't just unhelpful, it's potentially dangerous. Especially, she argues, because it can actively reinforce the very stigma that stops men from seeking mental health support in the first place.
So you have these different voices, an old school critic of certain feminist trends, academics looking at legal and cultural systems, a data-focused policy scholar, a contemporary journalist critiquing the discourse from within, plus insights from the men's rights movement, all converging on this idea that the conversation about gender and health bias has this significant blind spot regarding men.
Exactly, is the normalization of male neglect.
Normalization of male neglect.
Men's suicide rates being 3 to 4 times higher than women's globally, men being significantly less likely to actually receive mental health treatment, the stark disparity in research funding between prostate cancer and breast cancer when adjusted for mortality, the massive overrepresentation of men in dangerous jobs leading to injury and death, and specific conditions like male osteoporosis, eating disorders in men, certain autoimmune diseases being frequently underdiagnosed or undertreated in male patients.
These very real data-supported disparities are typically treated in mainstream health narratives or gender discussions.
They rarely feature prominently. They're not central to the main narratives about gender inequality and health. When these issues are mentioned, it's often only to place the blame back on men themselves, chalking it up to their adherence to toxic masculinity or the damaging effects of the patriarchy on men's own behavior.
So the explanation offered focuses on men's choices or internalized norms rather than potential systemic neglect or bias against men.
Intellectually lazy and morally hollow. It avoids seriously engaging with the possibility of systemic factors, cultural blind spots, or biases within healthcare and advocacy that might be actively disadvantaging men. It defaults to blaming the victim. Feminist health advocacy, in its push for gender equity, has, in some corners of the discourse, kind of hardened. It's ossified into a moral hierarchy.
A moral hierarchy. And in this hierarchy, how are discussions of suffering and disadvantage handled?
Within this perceived moral hierarchy, women's pain, suffering, and experiences of systemic disadvantage are readily acknowledged. They're validated, seen as unjust, and treated as demanding immediate attention and systemic solutions.
But for men,
In contrast, men's pain or disadvantage is frequently either erased altogether from the conversation, dismissed as unimportant relative to women's issues, or reframed. Often reframed as an inevitable consequence of male privilege itself, or as self-inflicted due to men failing to reject harmful masculine norms. It's seen as less urgent, less systemic, or somehow less morally compelling. Gender bias in medicine is real, absolutely. But it is not a one-way street that only disadvantages women. It's time to acknowledge the full complex picture that includes recognizing and addressing the measurable and significant ways in which men are also underserved, misunderstood, and too often left behind within the healthcare system and the broader public conversation about health and gender.
moving from overlooking men's health to potentially actively resisting efforts to improve it.
Yeah, some instances, the issue isn't just passive neglect or a blind spot within certain advocacy movements regarding men's health. There has been active resistance, sometimes even undermining, of efforts specifically aimed at improving men's health outcomes. Somewhere along the way, that righteous mission hardened into a rigid ideology. And they describe this ideology as one that, in their analysis, has sometimes led to a perspective where only women's suffering is seen as truly legitimate or worthy of advocacy resources and attention.
And men's suffering.
It's perceived sometimes as a potential obstacle or threat to the progress of feminist goals themselves.
Based on certain events or discourses, this isn't just passive neglect anymore, but has, in some specific cases, shown a tendency towards actual hostility. Mainstream feminist health advocacy often remains largely silent on these points.
When advocates or researchers who are specifically focused on men's issues try to bring attention to these very real gaps and disparities within broader gender discussions, they're often met not with collaborative concern, but with suspicion.
Suspicion. Framed how? Like they're trying to derail the conversation or just centering themselves.
Yes, men raising concerns about male-specific health issues in spaces ostensibly dedicated to gender advocacy are somehow seen as being inappropriate, as if they are being male in the wrong context and disrupting the proper focus.
This particular rhetorical move, What does it achieve?
It serves to reframe men's suffering. It stops being a human issue requiring empathy and action, and instead becomes a political inconvenience, something that messes up a preferred narrative or agenda. Consequently, any attempt to address these male-specific health issues is then cast as a kind of betrayal of feminist goals because it might divert focus or resources away from women's issues.
Opposition disguised as caution.
There has been open resistance in some feminist spaces or among certain feminist writers and scholars to the very idea of genuinely incorporating men's health concerns into the broader umbrella of gender advocacy or feminist platforms, not just overlooking, but actively resisting inclusion. Writers at publications like the Daily Tar Heel expressed concerns or explicitly warned that bringing men's mental health issues into feminist discussions could potentially undermine the goals of feminism or dilute women's voices, the fear being that it would redirect attention or finite resources.
Deeply problematic.
This perspective reveals something crucial. In some instances, advocating for men's mental health is perceived primarily as a threat, not because the issues themselves aren't important or severe, but specifically because addressing them might draw attention, resources, or focus away from issues primarily affecting women. Ideological gatekeeping. It shows a tendency within some parts of this discourse to prioritize protecting a specific ideological focus, rather than expending empathy or solidarity when faced with evidence of male suffering. It defaults to fear or territoriality over perceived rhetorical or political space, rather than a shared human concern.
There's also direct criticism of male-focused health efforts themselves.
Even specific, separate health initiatives aimed solely at men campaigns for prostate cancer awareness, efforts focused on male mental health like Movember, have sometimes faced criticism from feminist scholars or commentators.
And the nature of that criticism.
These criticisms often frame such male-focused efforts in negative terms, either as somehow reaffirming patriarchal norms, though how isn't always clear, or as unfairly diverting resources that, the critics imply, should rightfully be going towards women's health, often citing women's historical underrepresentation in medicine as the justification for prioritizing current resources exclusively for women.
And what is the source's direct counter-argument to this specific line of criticism?
A classic example of whataboutism except with lives on the line. While the historic exclusion and neglect of women in medicine was absolutely wrong and demanded correction, that past injustice does not logically or morally justify continuing to ignore men's urgent, pressing health issues right now.
Especially given the scale of the problems.
Exactly. This is particularly egregious, especially as suicide, addiction, and mental illness ravage male populations with barely a whisper from public health authorities, or, the implication is, from some corners of gender advocacy focused solely on women's historical disadvantage. Ignoring current crises because of past ones is illogical and harmful.
Then there's another tactic, the separate but unequal cop-out.
Yes.
Is a position where some individuals within feminist discourse might concede, maybe when directly challenged, okay, yes, men's health issues matter, they deserve attention, but then they immediately pivot and insist that these issues must be addressed entirely separately, in completely different channels, different organizations, away from women's health efforts or broader gender equality discussions. The ideological equivalent of separate but equal is a convenient way to maintain a singular focus on women's issues within the established, often well-funded feminist institutions and advocacy networks, while simultaneously it subtly discourages serious, well-funded engagement with men's health in broader public discourse, the discourse that aims for gender equity for all. It keeps men's issues siloed and marginalized. Where are these separate institutions? The multi-billion-dollar infrastructure, the national campaigns, the education programs, the powerful advocacy networks. These robust, well-funded systems dedicated solely to men's health simply do not exist on anything like a comparable scale to initiatives focused on women's health. Or, if they do exist, they are relegated to the fringe and often maligned, lacking mainstream support and resources.
So this exposes the separate but unequal argument.
Yes, and it exposes it not as a genuine plan for achieving equitable health outcomes for men, but rather as a rhetorical tactic to justify inaction or continued exclusion of men's issues from the mainstream gender equality conversation.
So pulling all these threads of critique together, what does this reveals about feminism today?
The silence, the suspicion, the resistance, the dismissal, the whataboutism, the separate but equal suggestion. Mainstream feminism has, in practice, if not always in stated intent, constructed a kind of moral and political economy where only women's pain counts, as a systemic issue demanding collective action.
And men's pain.
It's either actively erased from the picture or it's reinterpreted and dismissed by framing it as just a consequence of male privilege itself, or it's treated merely as a public relations problem, something that inconveniently distracts from the real issues affecting women. The movement that historically and rightly demanded full humanity and recognition for women has, in its contemporary form, become strangely dehumanizing when it's confronted with the undeniable reality of men's suffering.
Wow, okay. The overall conclusion for this entire section, bringing together all these criticisms of advocacy, is essentially a direct indictment, isn't it?
It really is. The common claim, the one you hear often, that feminism is fundamentally about equality for all, simply collapses under scrutiny when you examine its practical response or lack thereof to male vulnerability and suffering. In too many cases, feminism has failed men, not just by ignoring, but by actively resisting efforts to help them.
If not feminism, then what?
Right.
If the current dominant framework for discussing gender inequality is demonstrably failing to adequately address the suffering and disadvantages faced by roughly half the population, then what kind of framework do we actually need?
What kind of framework would address everyone's needs?
If we are genuinely serious about building a truly just and humane society, we need frameworks, theories, movements, policies that demonstrate genuine care and concern for all human suffering, regardless of the gender of the person suffering. And crucially, this care shouldn't be limited or constrained by whether that suffering fits neatly into a pre-existing political narrative or serves a specific ideological agenda. It needs to be broader, more universal.
Okay. One final major piece of data, both a forgotten crisis in itself and as a kind of ultimate litmus test for how seriously society and particularly gender advocacy movements truly commit to gender equity in practice.
And this core data point is the global male lifespan gap, the fact that men die younger than women pretty much everywhere.
Exactly. Across effectively every single one of the 200-plus countries where we have reliable data, men consistently live shorter lives than women.
And it's not a trivial difference.
No, it's often a gap of 5 to 7 years on average, and in some specific countries or regions, the gap is even wider than that.
So this isn't just a statistical quirk specific to one culture or a few countries.
No, it's a truly global phenomenon. It cuts across cultures, economic development levels, geographic regions. Globally, life expectancy at birth for women is 75 years, and for men is 70 years. A consistent worldwide 5-year average difference in lifespan favoring women.
So the key point here isn't just the existence of the gap, but the attention it receives. Or rather, the lack of attention.
Precisely. Despite this being a stark inequality, a fundamental systemic difference in the most basic health outcome, measured in years of life, gets virtually no attention in mainstream gender advocacy or in global health initiatives that focus specifically on achieving gender equity. You just don't see major global health movements, large international conferences, or significant UN campaigns specifically dedicated to the goal of understanding and closing the male lifespan gap. There's no widely recognized, well-funded, institutionally backed equivalent of, say, an International Men's Health Day that gets the kind of serious support, funding, or media focus that initiatives targeting disparities affecting women often receive. Why? Why this silence? Why this lack of focused effort on a universal gender disparity in lifespan?
Why do men die younger? It's not just simple biology, right?
It's a result of biological, social, and behavioral factors interacting. There's several key contributing causes. First, riskier behavior. The way masculinity is often socialized in many cultures encourages or even pressures men towards taking more significant risks, physical risks, emotional risks like suppressing feelings, even financial risks. This translates statistically into higher rates of behaviors known to shorten lives. Higher rates of smoking, heavier drinking, more reckless driving, greater involvement in violence both as perpetrators and as victims.
Occupational hazards are also a major contributor.
Yes, men overwhelmingly dominate the most physically dangerous and high-risk jobs around the world. Construction, logging, mining, commercial fishing, military combat roles, firefighting jobs with significantly higher rates of fatal accidents and serious injuries compared to the jobs most women do. This directly pulls down the average male lifespan.
Health neglect and stigma also come up again here as a cause of the lifespan gap itself.
Absolutely. Men's documented greater reluctance to see a doctor regularly, get preventative screenings, or seek help early when symptoms arise, often driven by that stigma. And the pressure to be tough means serious illnesses like cancer or heart disease are often caught later. Later diagnosis means treatments are less effective, survival rates are lower, and that cycle of emotional repression leading to untreated mental illness, potentially culminating in addiction or suicide, also directly subtracts years from average male life expectancy.
Medical bias, which we discussed earlier in terms of misdiagnosis, is also listed as contributing to the lifespan gap.
Yes, instances where men's symptoms might be dismissed or certain conditions overlooked because they're considered female diseases or pain is downplayed. These potential biases can lead to delays in getting the right care for serious conditions, which ultimately impacts survival rates and contributes to men dying earlier from treatable or manageable illnesses.
And suicide rates are a direct factor in the lifespan gap.
Yes, the stark fact that men make up around 75% of suicide deaths globally has a direct, measurable impact on average male life expectancy, especially because suicide disproportionately affects younger and middle-aged men, cutting lives short decades before they might otherwise have ended. It's a significant factor pulling down the average. Feminist discourse and advocacy, despite positioning itself as fighting for systemic health justice and gender equality, remains, in their critical view, almost entirely silent on this fundamental universal fact. Men everywhere on Earth are dying years earlier than women. Imagine the situation was flipped. Imagine if, globally, women consistently died 5 to 7 years earlier than men in every single country. What would a reaction be? It would rightly be seen as a global emergency. It would trigger immediate, massive, well-funded, billion-dollar international initiatives, urgent legislative action in countries worldwide, widespread public health campaigns driven by an overwhelming sense of crisis and moral urgency. We wouldn't accept it.
But the actual lifespan gap, the one where men die earlier, how is that typically treated when it's acknowledged at all?
Very differently. It's frequently dismissed in several ways. Sometimes it's just waved away as inevitable biological fate, a view the sources contest, emphasizing the large role of social and behavioral factors. Other times, it's framed implicitly or explicitly as men's own fault, a result of their adherence to toxic masculinity or making poor lifestyle choices. Or, perhaps most commonly, it's simply treated as a non-issue altogether, completely omitted from mainstream discussions about gender inequality and health outcomes.
It's just background noise. Yeah.
This global male lifespan gap is a litmus test for gender equity. As a social or political movement claims to be fighting for gender justice and equality for all, but it cannot or will not seriously confront, understand, and seek to address why one specific gender is consistently dying years earlier than the other everywhere across the globe, then that movement's commitment to justice isn't truly universal or equitable. It's selective. It's tribal, prioritizing the concerns of one group over the fundamental survival disparity of another.
How feminism, as a movement, has handled this specific measurable disparity.
Feminism has failed to take this profound and universal disparity seriously as a core issue of gender inequality. And worse, in some instances, the narratives and critiques originating from feminist discourse have actually reinforced the very cultural pressures and norms like dismissing male pain, framing vulnerability as weakness, encouraging stoicism that push men towards silence, towards neglecting their health, and ultimately towards self-destruction.
So that's the final major piece of analysis, a really stark look at the lifespan gap and a very critical interpretation of the lack of attention it receives.
Exactly. So having navigated through this really extensive analysis and critique covering everything from specific health disparities men face, the critiques of help-seeking barriers in the healthcare system, the deep dive into how gender bias in medicine is discussed, this critique of advocacy responses, and finally this stark look at the global male lifespan gap, we arrive at the end point, which isn't just a summary, but a set of questions the sources leave us with.
Right. These are provocative questions, questions intended for you, the listener, to think about further, building on everything we've just unpacked. Is mental health care, in the way it's most commonly practiced today, perhaps more emotionally tailored to the ways women are typically socialized to communicate and express feelings? And if so, is that inadvertently alienating men, making it harder for them to connect with and benefit from therapy?
Okay. The second question takes aim at public health campaigns themselves. Could public health messages sometimes unintentionally perpetuate the very neglect of men's health we've discussed by, for example, using male stoicism or traditional male roles to push messages primarily centered on female health? They give the example, real men get mammograms for their wives. Does that kind of messaging reinforce the idea that men's health engagement is mainly for others, not for their own sake?
The third question is broader, asking us to imagine something different. What would a truly gender-symmetrical health system actually look like in practice? Not just a system that adds women into research that was previously male-focused, but one that proactively identifies and addresses gender-specific disparities, barriers, and health needs for all genders, with fair resources and approaches tailored to each. And the final question brings it back to practical solutions. Given all the unique barriers, stigmas, and communication styles discussed throughout the material, what would genuinely effective, male-focused mental health outreach and support programs actually look like on the ground? How would they need to be designed differently from existing models to successfully reach and genuinely help the many men who are currently falling through the cracks?
These questions really push you to think critically, don't they? Using the analysis from the sources not just as information, but as a springboard for considering potential changes or entirely new ways of thinking about healthcare and gender.
Definitely. And one final thought, if we as a society are truly serious about building a genuinely just and humane world, one that values the health and well-being of all its members, then we fundamentally need frameworks, approaches, and movements that demonstrate deep and authentic care for all forms of human suffering.
And that caring shouldn't be conditional.
Exactly. It shouldn't be selective, limited only to the suffering that happens to fit neatly or conveniently into a particular political narrative or serve a specific ideological agenda. The commitment to alleviating suffering needs to be universal. Men are dying by their own hand from preventable diseases, from systemic neglect, and the ideological refusal to talk about that is costing lives. We don't need feminism to include men. We need to be honest about the ways it has excluded them and be brave enough to build something better.
And that brings us to the end of this very deep dive.